Yeah.
Good evening. We are live. We are awaiting for attendees to log in. We have open broadcast. We start at 7 p.m. sharp, and we've got 4 minutes. Our speakers are here with us, and our moderator tonight, Dr. Catherine Gitau, is here with us. We will await for 7 p.m. when we log in. Those on Facebook Live, do feel free, ensure that you can drop in your questions on the chat, and we will do our housekeeping shortly. Thank you.
Hi, everyone.
Hi, how are you?
Fine, thank you.
Hi,
Good to see
Prof.
you.
How are you?
Very well, thank you.
So good evening. We are on tonight for our mental health webinars, which we have been carrying on as a series every Tuesday. As housekeeping, today our topic is obsessive compulsive disorder, and our presenter is Victoria. Dr. Victoria is a consultant physician, and our moderator today is Dr. Catherine Gitau, alongside with our other presenter, Tina Masai, and our panelists, Yvonne and Professor Atuoli. So we look forward to having a great session tonight. We've been asked to wash our hands. We've been asked to keep physical distance. We are wondering how those with obsessive compulsive disorder are coping up, and it's an exciting webinar tonight. So on your end as attendees, your chat box looks like this. Do click on the chat if you have any comments or any discussions that you would want to hold there, either to everyone or to an individual. If you do have questions, click on the Q&A. The Q&A chat box looks like that, and you can input your questions. We will fill them to our presenters and our panelists tonight. You can either send it with your name on it, and we will appreciate your contribution to this webinar tonight, or you can send it anonymously and we will present it. Alongside with our presentations, we have the COVID-19, the division rounds that we do as KMA. You can join us on Friday nights. We also have a case management series that we have started every Tuesday at 2 p.m. Next Tuesday, we'll be having, this Thursday, sorry, we'll be having a presentation on yes, I'll share it later. It is on infection prevention for health workers. Thank you. So alongside, we've had sessions of mental health. We are now on our 11th session. Last week, we took a break. as a session to mourn our lost colleague who passed on last week. 3 of our colleagues, that is 2 nurses and 1 doctor that we had last week. So out of that, these are our resources. You can find them on the KMA website. We'll share our call center number and you can reach us on those numbers. So I hand over to you, Catherine Gitao, to take over the session.
Thank you very much, Dr. Joy Mugambi, for organizing this, and thank you for inviting me to be a moderator. I look forward to this evening, and with us we'll have our speaker, Dr. Victoria Wamuhoma. Dr. Victoria Wamuhoma is a consultant psychiatrist working at Mathare Hospital as a deputy medical superintendent. She's also the vice president of Kenya Psychiatric Association and the president of East Africa Young Psychiatric Association. That is just a few of the roles that she plays, and she's a good and great speaker, so we look forward to hearing from her. Along with that, we have Tina Masai, who is a clinical psychologist. She's been practicing for about 13 years now. Currently, she's working with people who have substance use issues and mostly injection or heroin addiction. And she's working at the Mathare Methadone Replacement Therapy Clinic. And most of the time she uses cognitive behavioral therapy as one of her preferred modes of psychotherapy. And we'll be looking forward to hearing from her this evening as she talks about cognitive behavioral therapy. Along with her, we have Yvonne Orlando, who is also one of our panelists. She's been here before, a very eloquent lady, and she'll be taking us through maybe some of the question and answer, during the question and answer session, she'll be answering some of the questions. We also have Prof. Atwoli. He's a man with many titles, and I don't think I'll manage to take you through all his titles, but we must congratulate him now that he's a dean at Aga Khan University Hospital, and we look forward to hearing from him. He's always very resourceful. So we'll start this evening by being taken through the session of obsessive compulsive disorders by Dr. Victoria Wamuhoma. Vicky, welcome.
Good evening, everyone.
Good evening, Victoria.
Okay.
Can I make it a slideshow? Yeah.
Is that okay?
Perfect, perfect. Thank you.
All right. Good evening once more. Thank you so much, Dr. Catherine Gitao, for the introduction. I chose the topic OCD because definitely everything that we are being told right now is everything that everyone knew that they were things that people with OCD were already doing. Being careful, being hypervigilant, washing hands, probably washing hands much more. And probably at the time, there was really no visible external stimuli that was stressing them to do that. But at this point, pandemic, we know that there's now an external stimulant, and I chose this topic because we want to see what is the impact of now what is happening in the world on persons with OCD. I would like to do the introductions. So OCD's obsessive compulsive disorder is a mental disorder that occurs when a person gets really caught up in a cycle of obsessions and compulsions. Would want to see what the obsessions are, what really obsessions are. In this case, obsessions are unwanted, intrusive thoughts, images, or even urges that trigger really distressing feelings. They can be feelings of fear, feelings of a catastrophe going to happen, or even feelings of intense anxiety. Then the compulsions are the things that now the individual engages in an attempt to get rid of these obsessions, or even in an attempt to counteract or decrease the distress, the fear, or the anxiety. Now, what is really key in OCD is that the patient spends a lot of time doing these kind of rituals, either in the obsession or in the compulsive acts, and that really gets into the way of their life or their activities or even their career. I would like to show that with this picture. So a patient, somebody with OCD, let's give an example why I chose this topic. So there is now coronavirus out there. So coronavirus, or that virus, is now the stimulus. So we know that it is out there. So what happens? We are being told that probably if you are breathing, there is a probability of breathing in this thing. If you are too close to someone, there's a probability of the person being unwell, or you might contaminate yourself by touching surfaces that are already contaminated. So that's what we call the external stimuli. Now, if you have the obsession, then this thought will keep recurring in your mind, which raises distress and anxiety beyond that which is normal and beyond that which is equal to the extent of harm that you're likely to get. And then you get yourself into this cycle where there is increased anxiety, increased obsession of the thought, increased anxiety, increased obsession of the thought. And to reduce this anxiety, then you get into a behavior which tries to eliminate this obsession. And unfortunately, in doing this, you can reinforce this behavior, and that's why in the end people with OCD find themselves locked up in a situation whereby they have the obsession, then the compulsion, the obsession, the compulsion, which is really traumatizing and time wasting. Now, there are 4 main common types of presentations in OCD. So we have the contamination type. This type starts with an idea of fear of a contaminant. A contaminant can either be a person, it can be an object, it can be a pollutant. And then because they get into the fear of that, then they have to do a compulsive act of washing. The other types of presentation of OCD is unacceptable taboo thoughts. So these can be thoughts, they can be images, or they can be urges. They could be of religious nature, unwanted sexual thoughts, or they could be violent thoughts. So an example of religious is that somebody might be having obsessional thoughts about doing a blasphemous religious act. And this thought keeps or it could either be a thought or it could be an image, and it keeps recurring and recurring and recurring. So they will try to do something to counteract that. It could be prayer, maybe prayer, so excessive prayer. So you'll read in text somebody saying, I'll have to do 30 Hail Marys. And if they do less than 30, then they really don't feel that that particular obsession has been canceled. So you find them having that obsession and then struggling to do something to counteract it. Another example, in an unwanted sexual act is people who have images of probably molesting children. So they have the image or the thought, and probably with time, to avoid having this kind of thoughts, they will start avoiding being in spaces where there are children, or maybe in life they'll even avoid having children themselves. An example of violence is there are people who can keep having obsessions about pushing somebody in front of moving cars. So they keep having this. These are kind of thoughts that might occur to us once in a while and they leave. I mean, sometimes you don't even notice it. But for people with OCD, it will be recurrent, it will be intrusive, and in many times it will also be unwanted. Then the other presentation of OCD is obsessions about harm. So people who keep thinking about, they are afraid and they are in fear of harming others or even harming themselves. So an example is a lady who every time she leaves the house, before she reaches the gate, she thinks, oh my God, probably I left the stove on. So many of us might think like that, and we counter check and we're like, no, I think I really switched it off. And then you continue with your day. But this person will come back to the house, check, go back, probably reach the gate, the same thing happens, go back, check. So then they end up, the compulsive act that they end up with is checking behavior or checking compulsions. And it can occur in many ways. The stove is not the only example, there are very many ways. This kind of people have also been known to exhibit a heightened sense of responsibility, so that they keep feeling that anything they do is like, if not done very well and in the right manner, is likely to bring harm to the people that they are responsible for. Then the last one is obsessions related to perfectionism. People who must just do it right. And if you do not do it right, then something will go wrong. Or if they do not do it right, their minds will just not settle. So these people, they will present with compulsions of symmetry, arranging, order, counting. So their desks will be perfect. And it will not just be perfect. You find that even in that, they will still be obsessed about even the distance in which these things must be arranged in. And if they do not have the opportunity to do these things perfectly, then they feel their minds will not settle. So a very good example for perfectionism in this time of coronavirus is we are being told that we have to keep 6 meter distance. I mean, people with OCD at this time, 6 feet distance, physical distance from others. Most of us will be able to just estimate the 6 feet or the 1.5 meters that we are supposed to estimate. But somebody with OCD will notice every single time somebody is not keeping that distance. And they will be disturbed in their mind at all times to perfectly keep that distance. So you are obsessed with it. And if that distance is not maintained, they will already be in a situation where they feel they were probably infected by the virus, or because things were not perfect at that time. Now, what is the pathogenesis of OCD? So there is the biological explanation. We know there's a part of the brain known as the striatum that has two nuclei, the caudate and the putamen, and they are involved in what's the word? So when you get sensory information, it needs to be translated to motor function. For example, if I see a speck of dust, then my hands move quickly to rub it off. So for most of us, if I see a speck of dust somewhere, you will quickly rub it off, and that's it, end of story. But for people with OCD, they will rub it, yes, but then some other information which is not properly filtered by the caudate nucleus starts coming in. Did you rub it? Did you really rub it well? So the what if thinking, did it really go? Was it really dust? So that kind of thing. So or maybe if it is somebody who is obsessed with order in a way that they have to do things in a certain manner for it to actually be perfect, then you find somebody starting to rub off the place probably 3 times if they have the ritual of doing things 3 times, and 3 times is what means that the thing is complete. Then they will rub that thing off 3 times. So that is the first explanation, which is biological, that there is probably a problem with the way the caudate nucleus filters information. Then we have other, if you look through literature, there are 2 men, there are 2 psychologists, Bruce M. Heyman and Sherry Pedrick, who really wrote up properly about the cognitive errors that people with OCD might have. So people with OCD, they really do overestimate risk. fine, there might be harm, but the heightened perception in which they overestimate the risk is really high compared to normal people. They tend to catastrophize. Previously, probably if there was no coronavirus and it was just about germs or about me leaving the stove on, you catastrophize. If I come back home today, I'm going to find my family dead from a fire in the house. Or if I touch this thing, then I'm done. I mean, I'm going to die. So they catastrophize. They have persistent doubting, and that's why you do one thing and you keep repeating. You are still not satisfied. You do it again, you are not satisfied. So things are not complete. Things are always incomplete. They also have the what if thinking. Okay, so I really did wash my hands. Did I wash them properly? Okay, what if I didn't wash them properly? What if I didn't put enough soap? What if I didn't really use the right amount of time that we've been told by CDC? What if the water was not the right temperature, so you wash again? What if the germs were too many? I didn't really clean them off properly. So there is that what if thinking. They also have intolerance to anxiety. Some of them might have magical and superstitious thinking, over responsibility, I've talked about it, and pessimistic bias. This particular pessimistic bias is very important to me in this corona or the COVID-19 time, and especially when it comes to how much information people with OCD currently are being told to consume, either from the social media or from literature. Generally, I will talk about that pessimistic bias when we reach there. I'll keep it in mind. So I'll not focus on the other three types of OCD. The one which is most relevant today is contamination type of OCD. So perhaps no group of individuals with mental illness is as directly affected by the worsening outbreak of COVID-19 as people who have this type of OCD. All the messages on frequent hand washing, which were previously considered excessive by them, are now actually what is being told to people to do. The scenario where they were once told there is no contaminant out there, now they are being told there's a contaminant, there's now a contaminant. So now how do you balance what is now excessive and exaggerated, and how do they balance what is supposed to be normal reaction to this particular situation that we are facing? So what has been found in literature is that patients with OCD, some of them actually experiencing worsening of OCD symptoms. And in that group are especially people who have comorbidities, depression, anxiety, bipolar disorders, or even eating disorders, or even personality disorders. Then going through some journals, I also found that people with traits of OCD, or people who previously had subclinical OCD, really were able to manage themselves and were really not that affected. But when this pandemic came, they are the people who have really tipped into what we call the clinical OCD. Now, for those who had OCD before, clinical OCD, and were being managed and had gone through successful CBT or successful affective treatments, it has been found that because they had already been equipped by skills on how to manage this, to manage their OCD, they are actually functioning well. Those who had never received any type of treatment are actually in a state of worsened state, and those who had the traits, or those who were subclinical and have now spinned into frank OCD, they are really struggling, and they are the ones who are now really being seen in clinics. I don't know about Kenya, but they're the ones who are now really being seen in clinics in other areas, being in crisis and going for care. The other thing that the pandemic has now brought on is that we know that exposure and ritual prevention was the gold standard of treatment of OCD. But at this point, is it really going to be the gold standard? Are we going to expose these patients to this particular contagion in a manner of trying to bring remission in them? So we will also see about that when it comes to treatment. So after several calls and several physicians seeing people with OCD and not really knowing what to do with them, the International College of Obsessive Compulsive Spectrum Disorders and also Obsessive Compulsive Related Disorders Research Network. I had to write this down because these two are the ones which have now produced a consensus statement with the aim of delivering a pragmatic guide on how to manage people with OCD at this time. So they give us some strategies to start with. The first one is that as a clinician, when you get a patient with OCD, take a compassionate and calming approach. So be compassionate to this person. Of course, we all know they are being irrational, they are probably exaggerating and all that. But all of us at this time are really anxious. All of us are, we are unnerved, but take a compassionate and calming approach, and also take into context that people are different, and even take into context that people are coming from different socioeconomic backgrounds. And this brings me to wonder, what happens to somebody who has OCD, the contamination type, but they live in Madare slums where they even can't access water. So they want to wash their hands, and even getting that water is a problem. I mean, how much time and how much resources are they really going to be spending looking for this water? I mean, because I think it just unbalances their lives. Also take a very careful history. Why do we take a very good history? It's because we want to rule out substance use disorders, which could worsen the prognosis, bipolar disorder, anxiety, depression, and other anxiety disorders, which would also need to be managed as you are managing this disorder. Assess suicidal risk. Suicide is usually not really associated with OCD on its own per se, but we also know that in many instances, OCD can be associated together with depression and anxiety. And when it is comorbid with those two disorders, that's when there is really a need to assess whether there is suicide risk. Provide psychoeducation. As a clinician, you should be able to provide accurate information to these patients. Provide for them information using the known risks. What are the risks? And what is the WHO or the CDC guidelines telling us about these things? CDC is telling us, wash your hands for 20 seconds. So give precise information. Wash your hands when you think you've touched contaminated surfaces, or you've been outside of the house, or you've been in several places. When you are in crowded places, wear a mask. Those are anything that goes beyond what the CDC really is giving us as a guideline, then is what we start calling exaggerated. And by being compassionate to these patients, and by relaying truly the precise information, just reinforces what is supposed to be right, reinforces what is supposed to be enough, and not exaggerated in terms of their reaction. Now, inquire about internet usage and news consumption. People with OCD have been known to consume as much information as possible, to use internet as much as they can, because they do not want any piece of information to pass by. Now, let's go back to pessimistic bias. Unfortunately, they also, because of how they filter information, they are likely to just pick on the negative news, negative reports, such that no matter how many good reports about this situation is being given, because of lack of insight, it becomes very difficult for people with OCD to actually put their minds on the positive reports, or it's very difficult for the balance, no matter how much the good report is, for the positive reports to still outweigh the negative. So patients are being advised to not spend more than 30 minutes, and also to only look for information on either CDC or WHO websites. That's it. Anything out of that, because again, we know that if they get the wrong information, they still tend to also pick it up. So that is the kind of advice that you would want to give somebody with OCD. Social and occupational care, there's very great value, and I think Tina will talk about this, in people with OCD, scheduling their activities, scheduling their daily routines, even if they are stuck at home. We know, number one, that they are very vulnerable to getting obsessed with rituals, their own rituals. Studies are now showing of people being stuck in washing hands even up to 10 hours. Patients are boiling their hands. Patients are bleaching their hands. I mean, so establishing a schedule where you are forced to get your mind out of these rituals and go and do something else and stick to it, then takes away the time that you would have spent in the ritual, and also gives you a sense of fulfillment that you managed to do something else other than ruminating in your thoughts and ruminating in your obsessions and following your compulsions. So this is really important for people with OCD. The other thing is that, especially if they are staying alone or even if they are with people, social connectedness is very important for them. So they should either have significant others that they call, they do telephone conferences with. And we also know that when the OCD, the compulsions are really strong and powerful, they tend to involve family members in it. So everybody in the house will also be asked to wash hands. Everybody in the house will also be asked to bathe or engage in all these compulsive acts, which can really bring a lot of conflict in the family. And just being socially connected with others out there might actually bring in perspective. So at this point, if somebody with OCD comes to you for treatment, what's going to be the first, how are we going to treat them? So the first line that is being recommended by those two organizations that I talked about again is pharmacotherapy as first line, and giving SSRIs, fluoxetine, escitalopram as first choice, starting with very low doses and titrating the doses higher. If that does not work, then you can add a second SSRI, so that there are two, and clomipramine can always be given as a third drug. Now, if that still does not work, there is still room for adjunctive low-dose antipsychotics. So you can give aripiprazole, olanzapine, quetiapine, or even risperidone. Then the other thing is that it's very important to ensure that your clients are adhering to the treatment, because some of them, I mean, they may forget. They would have been probably very busy with their rituals. So they really have somebody in the family, if they're staying with family, has to be there to ensure that they are adhering to their medication. And if they're staying alone, then currently we have several apps on phones like that can be used to remind you to take your pills. And then there is the role of CBT. Medication alone may not work. And there is a role of CBT that needs to come in to try and correct all the cognitive errors that people with OCD have. And I'll give Tina a chance to talk about that. Thank you very much.
Okay, thank you, Vicky. Thank you very much for the very good presentation. You've done quite a good presentation, and it was quite clear. So we'll listen to Tina Masai. I hope you're ready.
Yes, I am. I will just not have my video on because my electricity has gone, but the show must go on. So good evening, everybody, and thank you for making time to join us today. I will be walking you through the psychological interventions for OCD, but with a specific focus on cognitive behavior therapy. And I will also share some practical considerations that can be used at this time, some of which Dr. Victoria has already touched on, right? So OCD, why CBT, cognitive behavior for OCD? There's actually a very strong evidence base for using cognitive behavior therapy to manage the symptoms of obsessive compulsive disorder. A lot of studies have been done and they found it to be efficacious for both one-on-one sessions, meaning individual sessions, as well as group therapy sessions. And CBT as a modality has also been applied in computer-assisted self-treatment and has been shown to have promising outcomes. So the data out there is good. There's also a lot of data that is showing combination of pharmacotherapy and psychotherapy, specifically CBT, has been shown to reduce to cause symptom remission, and for even periods of at least a year or more. So there's a strong evidence base for this. So I would like to walk you through some of the things that would be covered in cognitive behavior therapy if a patient was referred for OCD management. So one of the things that we would have to do is conduct an assessment and conduct treatment planning based on what Dr. Victoria has mentioned to you all. Not everybody presents with the same types of obsessions and compulsions. So even though there's a diagnosis of OCD that has been made, you have to do an individualized assessment and come up with a treatment plan that is tailored to them. In addition to the psychoeducation she mentioned, we also still have to do psychoeducation. We have to provide some relaxation strategies, and that is what breathing and de-arousal does, just to reduce the anxiety. We are going to conduct something called subjective units of distress and ranking, and I'll tell you a little more about that and why it's important. We will conduct some form of exposure, and the exposure that is recognized for cognitive behavior therapy is exposure and response prevention. We will also work on the thoughts, identifying the maladaptive thinking patterns and challenging those. Dr. Vicky had already talked about the cognitive errors. Those are some of the things that we would address in challenging the thoughts and the dysfunctional beliefs. We would also try our best to identify the things that are maintaining the anxiety, neutralizing behavior, and work on reducing that. So for example, somebody who is worried about washing their hands, but they're in a situation where they can't wash their hands, they perhaps would count repeatedly in their heads or think about the process of washing their hands. So they may look like they're maintaining their anxiety, but within their mind, they're practicing certain neutralizing behaviors that just maintain the anxiety. So it's important to identify those and to come up with strategies of managing them. I'll also discuss with you a few considerations around managing OCDs, some of which Dr. Vicky has already touched on. So the first one is psychoeducation. So everything I'll walk you through, I'll tell you what the primary goal is and the tasks or the practical areas that are covered. So the main goal with psychoeducation is just to build insight in the client. And some of the things we would look at is the symptom presentation based on them, the impact that it's having on their life. Many people want to understand what the cause is. So you would share the cause based on the literature that is existing at the time. And then you will inform them and educate them about treatment, what the role of medication is and what the role of psychotherapy is and where they align. When it comes to symptom assessment and treatment planning, the main goal is to tailor an intervention that is individualized to the needs of the client. There's a number of assessment tools that are used. There are some that are clinician administered. One of the common ones is the Yale-Brown Obsessive Compulsive Scale. There are also some self-report scales which you're able to give to the client or the patient and they can fill. One common one is the Obsessive Compulsive Inventory. Then with treatment planning, there are different types of worksheets you can use. So some of the worksheets that I've used help to identify the triggers. So they list the types, the things that trigger the obsessional thoughts. They list the rituals. They list the behaviors they use as a form of avoidance. Then some of the areas we will cover as well during the assessment is the rationale of the treatment activities, because the more they understand the rationale of the treatment and what it's supposed to achieve, the better the more likely you are to engage them. We will also discuss the duration of treatment, which is the number of sessions as well as how long each session will last. This is very important because when you come to exposure and response prevention, those are sessions that could take anything between 45 minutes to 2 hours. So it is important for them to be aware of that from the beginning. It's important to let them know that the intervention is not purely based on the session they undertake, but also the homework, the practice they go and do at home. And I'll tell you a little more about that. And it's important to have their engagement on this. Some studies that have shown, some studies that were looking at prognostic factors looked at CBT. For those who receive CBT, for those who actually do their homework, their treatment, the prognostic factors were actually seen to be better than those who did not engage in doing the homework. Then you also have to discuss a strategy for how to manage the neutralizing behavior. There are certain rules you have to set prior to the exposure. Vicky had talked about some of them, limiting the amount of time, limiting the amount of contact you have with information, spending a fixed amount of time in hand washing, following only the rules that have been given by CDC of the national government. So those have to be rules that are set at the beginning and have to be very clear. Then of course, the assessment exercises that I mentioned earlier. Then when it comes to breathing and de-arousal, part of the core of OCD is anxiety and distress. So one of the interventions that has been found to be very effective is breathing exercises. So the main goal of breathing exercises is actually to teach them an anxiety management strategy. And what is usually done is just deep breathing exercises, focusing on breathing from the stomach, deep breathing in with the nose, hold for a few counts, and then breathe out for as many times as they need to until they feel calmer. Then we go to the symptom ranking. So when somebody comes presenting with OCD, there are a number of obsessions and compulsions they may have. And not all of them would rank the same in terms of severity. So perhaps contracting germs in the house, contracting COVID germs in the house may not rank as highly as contracting COVID germs in a hospital. So you ask them to list all the obsessions, all the compulsions they have, then they subjectively rate them. What is most distressing? What is least distressing on a scale of 0 to 100? Then what you'll do once they've listed all of them is you work with them to re-rank so that you can start from what is least anxiety provoking to what is most anxiety provoking. So this becomes very key because this will form the basis of how you will gradually start working on the obsessions and the compulsions. So therein goes the prioritization. So once you're ready for that, we now go into the exposure and response prevention. So the main goal around that is one, to introduce the client or the patient to what they fear, to reduce the amount of time they spend in those rituals, the obsessive compulsive rituals, and also to just help them manage the anxiety that they experience when they are exposed to a trigger. So the first thing you do once you have ranked your SADs, we can call them SADs, the subjective units of distress, you take the lowest one, set ground rules around that, come up with a plan for the initial exposure. So where will you be? Where will you do it? How long will you do it? You remember to use your breathing exercises, set rules around if it's hand washing, you can only wash for X amount of time using the guidelines that have been stipulated by the national government. And then once you do that, you encourage them to stay in the situation until the anxiety reduces. So the core thing about this, when you provide psychoeducation, you help them understand that their biggest fear might be that the anxiety will be overwhelming. But when they stay in the situation, the anxiety will surely peak, but after a while it will reduce. So what tends to happen is as you continue to re-expose to the same thing over and over, the anxiety reduces to a point where it's no longer distressing. Once you're able to achieve that with the lowest ranking, you move to the next rank. Set the ground rules again, plan for the exposure, review the coping strategies that they will use. And then again, they expose, try and remain in the situation, use anxiety management strategies. If they're able to do that successfully, over time, the anxiety for that particular trigger will reduce and you move up the hierarchy all the way up to the top. In addition to that, you work on thoughts. Vicky has already mentioned that there are a number of cognitive errors. They overestimate the risk. They have a very inflated sense of responsibility. If I don't wash my hands, everybody in the house will get COVID and they'll die. In other obsessions, like if I don't switch off the gas, maybe the house might explode. So they assume that if they don't take responsibility for this particular obsession, then everyone will suffer the consequence. There's also the tendency to overestimate threat. There's perfectionism, overimportance of thoughts, and the need to control thoughts. So these are some of the things Vicky had mentioned. So the main goal around thought challenging is to dispute those irrational thoughts and irrational beliefs. So the tasks that we would use in CBT is what is called cognitive restructuring. So to help them identify the thoughts, to help them identify where the thoughts are irrational, and then to guide them to look at the thoughts objectively. So look at factual evidence that supports their belief that everybody will die if they don't wash their hands, and then look at factual evidence that disputes. This person perhaps has not washed their hands. Have they died? Was there a time you didn't wash your hands as thoroughly as you had intended? What happened? So over time, they learn how to dispute the thoughts and reduce that overestimation of threat. But this is something that would require quite a bit of work. Then the other considerations that we have is once somebody learns the new behavior, they are encouraged to continue using that new behavior every day in all situations. So it has to be carried over to daily situations without fail and with consistency. Unfortunately or unfortunately, because of the nature of OCD, you have to be cautious about when you provide reassurance regarding the possibility of danger or harm. So in a situation like this, it would be reckless to tell somebody that, oh, you know, even if you don't wear a mask, nothing will happen. Or if you wear a mask and you maintain this, the risk is still there. So it's important to provide accurate information and not reassure in a way that would cause more harm. Then of course, because this is a graded exercise, it's important to continue assessing the client over the course of treatment. It is possible for them to go up the scale to some of the higher obsessions and compulsions, then have a reemergence of something that you had already worked on. So it's important to go back down and start building it up again. Sometimes the gains of a lower ranking obsession actually cascade to a higher one. So it means that there are certain areas that you may not have to work on because the gains have been carried forward. So it's important to keep assessing the progress. Then because OCD is something that affects the family, that it's very important to engage in the family, in the rule setting, the planning for the exposure, because there'll be a big consideration, or there'll be a big factor towards how well the exposure turns out. So now we come to COVID. What are some of the practical things that you can assist your patients to do to cope with OCD in this time? Some of which Dr. Vicky has mentioned. So one of them is just, again, helping towards insight. Help them recognize the unhelpful and worrying behavior. The core, again, of OCD has anxiety and distress. So anything that allows them to engage in a relaxing activity will help to reduce the anxiety, which will help to reduce the distress. Create a sense of order, routine, structure that can help you cope with the uncertainty. Reduce on the news watching. Then when you're able to identify the unhelpful or worrying behavior, which comes with unhelpful thoughts, use cognitive restructuring and disputation to help accept the uncertainty that comes with this time that we are in. Then of course, encourage them to follow what the national recommendations are on safety and hand washing. So if they are uncertain about how frequently they should wash, just refer them to what does the government say. Prior to COVID, what I would do is print the WHO hand washing guidelines, and we set rules based on that. So something very standard, very evidence-based. Then of course, to encourage them as well to practice self-compassion, because with the anxiety comes the distress of feeling anxious and getting angry at themselves and frustrated because of that. So encouraging them to recognize that this is actually an anxiety-provoking situation. There is a sense of threat, and to be kind, to be patient to themselves. Then of course, to practice self-care, the basics of making sure you eat regular balanced meals 3 times a day or 2, exercise, practice good sleep hygiene, engage in hobbies, and of course ensure that you connect with loved ones virtually where possible. So now I'll take you through some problems that have been listed. This was posted in a leaflet in the National Health Service website, but had been developed by a team of psychologists in Oxford. So they came up with specific problems that somebody with OCD might struggle with now, and then what to do instead. And what to do in this case is anchored on some of the OCD management strategies for CBT. So if they want to wash their hands because they're in doubt. Are my hands as clean as I thought? What if I didn't wash them as I should have? Just remind them to wash their hands according to the government guidelines. If they are scared of touching items in their home because of risk of contamination, to gradually work on touching items in your home as you usually would or as other people in the house are doing. And then washing after touching any object, again, just follow what the government guidelines have stipulated. Trying to feel completely certain that your hands are not clean. So this is more the obsession. The recommendation is still to wash according to the government guidelines, but to also trust that first impression, because usually a heightened sense of threat will allow you to see whether your hands are clean or not. So to be able to trust that impression, and because they've washed thoroughly, to also accept the uncertainty that would come. Then also in terms of trying to wash hands perfectly, just follow the rules that have been stipulated and not necessarily to the point of perfection. In terms of using strong chemicals or multiple chemicals to clean your hands, just again, wash according to the government guidelines, and then remind them that if we really did need those chemicals to get rid of corona, then they would already be in the recommendations. That they are not there must mean they are not needed at this point. So I think it's a little bit of a broken record recommending that they go back to what the government says. I'll skip to the second one because the first one is similar to the previous ones. In terms of seeking reassurance from others, trying to feel certain about a symptom. So you, rather than seeking reassurance, share your fears. So I'm anxious about this, I'm worried about this, as opposed to trying to seek information that is aimed at getting reassurance. Then of course, for the repeated checking of the internet, this is where the rules of reducing the amount of time you spend checking, the frequency within the week that you check, and where you seek the information. And then in terms of trying to work out how the contamination might be spreading, is just to try and work on cognitive restructuring to help tolerate some level of anxiety. And of course, encourage them to just be prudent and follow the safety measures that they should. So I think that's it on my side. Maybe the only other thing I could mention is in terms of prognosis. There are a number of things that the studies had shown in terms of what would make a favorable or an unfavorable prognosis. And I would love for the panelists to also chime in on this and say. So one of the things that I found is that age is a factor. So this was slightly, again, under dispute, because one of the things they said is early to mid-childhood tend to have a more favorable prognosis as opposed to an onset that is adolescent and later onset. However, there are other studies that say something different. Of course, they said low severity has a more favorable prognosis than a higher severity. Somebody who's experienced a shorter duration of illness is likely to have a more favorable prognosis. Of course, combined therapy. For those who discontinued after prolonged treatment, prognosis is likely to be better. For those who follow up with their homework in CBT and follow it up as it should, the prognosis is likely to be better. Then in terms of family involvement and the family reaction to the patient, the families that accommodate the OCD symptoms more negative outcome. For those who have a higher emotional expression to patient symptoms, so they get more distressed, more frustrated, there's also a correlation with a negative outcome. Then of course, a premorbid obsessional personality was also linked to a negative outcome. And then generally CBT seemed to show poor outcomes for hoarding symptoms. Then in the ones that had mixed results is level of insight, comorbid psychiatric diagnosis, and cause of illness. Meaning, is this somebody who has had OCD for a long period of time continuously, or is it episodic? There wasn't any concrete conclusion on that. So that is all on my side. Mugambi, I give it back to you. Or Catherine.
Okay, thank you, Tina, for the very good presentation, quite insightful. It's been great to hear more about the therapies that can be used in OCD. And now the challenge has been thrown, I guess, to the panelists to at least discuss a bit on the last slide that you have talked about on the prognosis. I think you mostly wanted us to discuss more on the age of onset, and we can discuss a bit around that. And I would request Prof, if he's still here with us, if you can make a comment on that, on the prognosis and the factors that you have discussed.
Yeah, thank you very much. I think Tina has done a brilliant job with the factors associated and with the prognostic indicators. Lots of research going on. So it's fair that there are controversies about whether, people who started having symptoms in early childhood would have better outcomes than people who started having symptoms in adolescence and early adulthood, and so on. So there's lots of discussion around that, because conventionally we would think that people who have a longer duration of illness would probably have a worse prognosis. But this is still something that is still being studied. But perhaps because even the symptoms of OCD in childhood in general would often come as part of other syndromes as well. So comorbidity is common, and comorbidity between OCD and developmental disorders in children is also very high. And so perhaps that muddles up the thinking around prognosis a bit, because if those other comorbid conditions are managed early and the children are able to, grow as near normal as possible, then the OCD doesn't become as distressing as if it comes later and then they're not as well managed. So I think that's the only comment I would make about prognosis. However, I would add that in the context of COVID-19, as the presenters said, one thing that COVID-19 does is to heighten anxiety, and anxiety worsens symptoms of COVID-19. And additionally, anxiety disorders are also commonly comorbid with OCD. And so with a threat out there, even if the symptoms of OCD are unrelated to the cleanliness and so on, they would still be worsened by the anxiety that the person experiences as a result of COVID-19. And the second thing that I would add is that in consideration of treatment, the recommendation at this time is that it appears easier to find medication and give them to deal with the symptoms of OCD and the anxiety as quickly as possible. And as Victoria pointed out, SSRIs, try one. If it doesn't work, try another. If two of them don't work, go for what did you say? An analog of amitriptyline. We have amitriptyline a lot more here. So a TCA can be useful after failure of SSRIs. With partial response to SSRIs, you can add an antipsychotic, especially if patients have other things like tics and so on and so forth. What is advised is, as much as possible in the context of COVID-19, try and find things you can do digitally. If you're going to do any of the cognitive or behavioral interventions, try and find things that you can do using a medium such as this one that reduce direct contact. One of the things that is proposed is that the exposure treatment perhaps would not be best in the context of COVID-19, especially if the symptoms have to do with the fear of uchafu and cleaning and so on. So you might not want to go down the route of the exposure treatment in this particular context. And finally, one of the things I find helpful when discussing symptoms of OCD in the context of COVID-19 is that as far as cleanliness is concerned and touching things is concerned, the bigger worry is getting your hands to your face. So, I mean, the fact that your hands are contaminated is not a direct risk. The bigger risk is getting your hands to your face. So perhaps if they focus a little bit more on avoiding touching their face, it might reduce the anxiety related to the fact that my hands are contaminated and I need to clean them more often. So those are some of the things that I would incorporate into the strategies that have been proposed. But I think the speakers have done a brilliant job with this subject, and I don't have anything else to add. Thank you very much.
Okay, thank you very much. And clearly they have done a brilliant job because there are not too many questions coming in. I do just come up on the Q&A for maybe Dr. You can comment on this.
I have a question. I don't know whether, can I ask a question? Hello?
Yes, feel free, Dr.
Oh yeah,
Samba.
hello Joy and everyone. Good evening. Hello?
Can
I
hear
be heard?
you.
Oh,
Yes.
thank you very much. Good evening, everyone. My name is Dr. Somba. Yeah, I was going to ask the presenters the risk of this condition in normal people. What are the risk factors of OCD? Who can get it? Is it everyone or everyone exposed to the COVID stress? Or are there people who are susceptible, who can be susceptible to this condition? And then the other thing I want to know is the length of treatment of CBT. How long can you treat this patient to recover? So these are the questions I really want to know the answers. The risk factors and the length of treatment using the CBT method. Thank you. Hello?
This is Dr. Victoria. I think I can answer the first question, which is what are the risk factors?
Respond to the question on CBT.
So would you like me to go first?
Yes, Tina.
Okay. So thank you, Dr. Somba, for your question. CBT sessions typically, standard CBT sessions typically run anything between 6 to 8 to 12 sessions, about 6 to 12 sessions. So for OCD, because of the nature of the sessions that you need to have and the number of sessions, those are likely to go up to about 18 or 20 or so sessions. Usually, a number of insurances are open to the treatment and are usually able to cover. But I don't know if there's anyone who has an alternative view on it, because they do recognize cognitive behavior therapy as a form of treatment. Yeah, and usually for patients who are able to do it completely, if the symptom severity is not too bad and they are responding to treatment, usually you're able to complete within that estimated 18 or so sessions.
Okay, thank you, Tina. Dr. Victoria?
So thank you, Dr. Somba, for the question, and I'll try to answer the question on what are the risk factors. So first of all, OCD does not affect everyone. It affects around only 1 to 3% of the population in places where that prevalence has been studied. So it's not it's a big proportion of people, and recently WHO has also classified it as one of the most debilitating mental illnesses. People who are at risk are the risk factors are genetic, and you are likely to get OCD if you had a parent or their relatives in your family who already have OCD. The other people who are at risk are people who already have what we know as the obsessive compulsive personality disorder. They are also at a risk of developing OCD. And then for those who just have the subclinical OCD in them, at this point when we have COVID-19, they are the ones who are likely to now tip into the true clinical picture of OCD. And just like many mental illnesses, no matter what happens, it's not usually everybody who is susceptible. They're just those people who are already vulnerable to it, either by genetic factors, hereditary factors, or personality. And then it can also be made worse by the fact that it's an anxiety disorder, which can be associated with other anxiety disorders, bipolar disorder, depression, and sometimes even suicidal risks. So it can also be comorbid to other mental disorders that other people might have.
Thank you.
Thank you, Victoria. There's also another question that has come in. How can one prevent OCD?
So I'll answer that. Then I'd like Professor Lukoya Toli to add on to. I don't know how you can prevent OCD, because OCD gets you unawares. I mean, it's a genetic illness, so you find yourself already starting to show the symptoms. But once it comes and it can be picked, then it can be managed either using the medicines that have been said by a psychiatrist, or using CBT, going to a psychologist. So you can control. But preventing, I've not seen any literature where, because then all of us will go to prevent OCD, really.
I agree, Victoria, that in the context of the continuum of health, prevention would probably be more like early diagnosis rather than preventing it from occurring, because the etiology, as it is with most of the mental illnesses, is biological, psychological, and social, where the biological plays a huge role in determining your predisposition to getting that condition, partly through the genetics that somebody is born with. And then the environment plays a role in determining probably when it will happen based on the triggers in the environment and the factors in the environment that will protect you. And your psychology, how your personality and so on determines how you'll handle the symptoms when they show up, or how severe they will be, and so on and so forth. So if you want to prevent, what you're preventing is severe complications of the illness. What you're preventing is the severe social disruption that will be due to the illness. What you're preventing is the interruption in progression socially that can happen if the illness is not managed. And you prevent that by diagnosing it early and then initiating treatment early and ensuring that the person is adherent to the treatment protocols that you agree on. So that is a way of preventing those adverse outcomes. Eventually in future, maybe in 20 years, and I'm being very optimistic,
thank you,
we might identify gene therapies that might help prevent it from happening at all, but not yet. Research continues.
All right, thank you very much. We'll just take the last question before we close the meeting. Please comment on self-management.
It's appearing.
Sorry, I think we lost Catherine for a while.
Tina Masai to comment on that.
Yeah.
I lost you for a moment, but I think you were asking on self-management. Is that the question on self-management if pharmacology is not an option, right? Okay. Yeah. So definitely information is helpful. That's always a good place to start. The more you know, the more you understand, the more you're empowered. When you have a solid understanding of the fact that these are symptoms that are not necessarily a reflection of the true threat, then the first step is to learn to manage the anxiety. So breathing exercises, relaxation exercises, maybe even referencing, external referencing. I seem to be distressed by this thing and I'm very bothered by this thing. The people around me do not seem as bothered as I am. So that can become an opportunity for you to start to challenge the thoughts that you have. So objectively looking at your thoughts and challenging, what if I wash one less time? Will something bad happen to me? And look at people who wash once as opposed to you who washes five times. So that kind of disputation can actually allow you to start to address. Then more importantly, if you're committed to conducting continuous sessions, these days there are online versions of CBT sessions. So it could be a matter of identifying CBT sessions, free CBT sessions that are for OCD, and it's possible to go through those self modules, and those could actually be helpful. But of course, if symptoms persist, it would be beneficial to get medication and do a combination of both.
Okay, thank you very much, Tina, and thank you, for the great and insightful presentation. And thank you to our panelists for adding quite a lot of info on what we have already learned. And now I hand over back to Joy, Dr. Mugambi.
Thank you very much, Dr. Gitao. Thank you very much, Dr. Gitao and team. Thank you very much, Victoria. That was very insightful. And Tina Masai for that very elaborate presentation. Before we go further ahead, I would like to thank, we have some special guests. We didn't only have health workers in tonight's webinar, we had engineers. We have Grace Kagondu, who is from the Institute of Engineers of Kenya. And I believe she shared this with also other engineers who have joined us tonight. We have Dr. Mishra, who's always here with us. Gerald Njenga, thank you very much for being here. Isabella, thank you. We also thank our Andrew Adrian, who's also here, Michael, Sharon, thank you very much for being here, and thank you for those great comments. They've all said this was a very great session. Thank you, Professor Lukoy, for always being here. Before this is one of our first sessions with our new KMA executive. Our president for KMA, newly inaugurated, Dr. Were, is here with us. He'll say something shortly. I will share what we have been doing in terms of our learning in collaboration with Kenya Psychiatric Association, Clinical Psychologist Association of Kenya, the National Nursing Association of Kenya, and the Clinical Council, the Kenya Clinical Officers Association, alongside with KMPDU. We've had a lot of learning activities that have been going on, activities that are going on around the counties, but online. These are our learning activities, and our call center number, which as of today has hit 40. Since its launch. It's been active in the last 1 week after we lost Daktari last week. So out of the learning activities, we have the Picha Kucha night, which is specifically for KMA, but we do invite members. We go around the counties. We get to hear what the counties are offering. We have these mental health webinars, which we offer every Tuesday night at 7 p.m. Do join us. On Thursdays, we have started out the case management webinars. Last week, we had home isolation guidelines for COVID-19. This will be on our YouTube page. If you want to refer back to it, you can check onto it there. And then we'll also archive it within our website, where I'll share the link to our website. This week, on Thursday, we have one for IPC for health workers, and do please join in on Thursday at 2 p.m. up to 3. On Fridays, we do the division rounds, which are the Picha Kucha night. Picha Kucha is chit chat in Japanese. We just basically want to sit on Friday in a relaxed mode and chit chat, get to know what each division around in terms of their engagement with counties, what are they doing, how are they managing their COVID cases. And we've learned quite a lot when we are going around through the divisions. So this is our call center number, 0800 720 608. Do reach out. We all have 1 or 2 issues that we need to talk to someone. Reach out, you'll be helped. Catherine and Lisa Hemba are manning those centers along with the nurse team and the clinical officers team, and they are doing a great job there weekly. Do reach out to them, talk to them, even if you just need someone to just talk. Our resources are archived in the KMA resource portal, which is on the website, and you can reach out and get to know more about all these webinars that we have held. Most of them are on the Facebook page and others are on the YouTube page, and the YouTube and the Facebook link are on the website. So without further ado, I will welcome Dr. Were. For CPD points, the KMA members and the doctors, your CPDs will be sent on your email. Please give a maximum of 7 days because processing and alphabetical order, sorry for the one with the letter Z as an alphabetical name, you receive them as the last. Like here, the letter A's, they receive them as the first. For the nurses, a link will be sent with the email that will reach you out either tonight or tomorrow morning, and the link expires tomorrow at midnight. So do use it in good time. We've not received any CPD info from the clinical officers, but we do hope that they will send out. So without further ado, I'll welcome our president, Dr. Were, who will handle the closing remarks and give us a word. Welcome, Dr. Were.
Thank you, Jude, for having me. Thank you all the members of KMA and also other guests who attended this important webinar on OCD. I'd like to special appreciation to
remove nearer the microphone. Nearer the microphone.
Special appreciation to Professor Lukoya Toli, Dr. Catherine, Tina, and Dr. Joy, and Dr. Somba from Nanyuki for putting this together. I also want to appreciate members of the who we are serving with, Dr. Gondu and Dr. Super, for joining us this evening. So I thank all of you for attending this particular webinar, and I hope you'll continue joining us as we continue the public this COVID-19 pandemic. All the healthcare workers to please use dial in into the number that was shared by Dr. Joy, so that you can also get someone. Don't just stay at home and struggle by your own. Otherwise, thank you so much. We hope to see you in our future webinars.
Okay.
Thank you. Have a good night, and asante sana to our presenters. Have a good night and a great week ahead. Join us on Thursday for the case management. You need to know how to protect yourself as we manage COVID.
Thank you very much. Bye-bye.
Good night.
Okay. Bye. Good night.